بسم الله الرحمن الرحيم. شكرا جزيلا دكتور مازن على الانفيتيشن هذه لإعطاء محاضرة في مؤتمركم القيم إن شاء الله. أنا إن شاء الله راح أنطي في المحاضرة عن يعني lateral canals, can they be managed non-surgically, وإن شاء الله راح نراويكم many cases how we can manage these canals. أنا دكتور حسين فيصل الحويسي. أنا من the College of Dentistry, University of Baghdad, the coordinator of the Iraqi Endodontic Society, or a member in the European, Arab, Asian, and International Federation of Endodontic Associations. The topics of the lecture, they are going to be about the anatomy of the apical part of the tooth, the principles and procedures of treatment, cases, follow-up, and literature. The main enemy in endodontics is bacteria. As you can see here, bacteria is harbored in the smear layer, in the dentinal tubules, and there are many types of bacteria, cocci, Phyllis, everything. So we've got many problems in endodontics. Sometimes they are simple, sometimes they are difficult. Just like this case, a very big lesion that was associated with non-vital 4 teeth. So we have to deal with this case and see the apical the terminus area of these teeth. We have to obturate them and then make a good area for healing of this lesion. And as you can see here, the lesion is gone. Infection might spread apically, but it may go coronally. Why is that? Because the exit of the pulp may be from the main exit, which is the apical foramen, or it may be through lateral and accessory canals. And this is very abundant in the apical region. The prevalence of the lateral canals, it was seen by Huang et al. He stated that in the apical region, the lateral canals, it is present in 49%. What is really alarming is that out of this 49%, only 7% were filled. So the rest were left untreated, uninstrumented, unirrigated, unobturated. Ricucci et al. Or Ricucci Sequeira stated that 75% of the teeth, they've got lateral canals and apical ramifications. Another study stated 79%. So really it's a problem. We have to address it. In the apical region, we may see one lateral canal, we may see two lateral canals. In the middle area, we can see the lateral canal is available and associated with a laterally positioned lesion. The same here, and here it is associated with a bifurcation involvement. And the lesion is very, very clear here. So it is very important to treat this canals in order to heal such a lesion. This is an upper sixth of a palatal canal. This is in what we call the invisible zone, whereby there's a lateral canal and a laterally positioned lesion behind the tooth. This is palatally. So it's important in such cases to use CBCT for diagnosis of the problem. The relation of the periapical lesion and exit of the pulp canal, here we've got a case that has double periapical lesions, one apical and one lateral. Why is that? Because there are two routes or exits to the pulp. Complete obturation to these exits will ensure that these lesions will heal in the future. So the previous thoughts about lateral canals is that we used to think that there are less bacteria in the lateral canals. The soft tissue in the lateral canal is separate from the main canal, and it doesn't have a serious pathological effect on adjacent teeth or adjacent tissues. But Ricucci and Sequeira showed us that the lateral canal is filled with uninflamed pulp or inflamed pulp or bacterial biofilm in the main and lateral canal. So really it is joined with the main pulp tissue. So what do? Principles and procedures. First of all, we have to have a good access to the apical region. Therefore, we have to enlarge the canal orifice to an acceptable width. Previously, we used to have rotary instruments that have a width in the orifice region of 1.2 millimeter. Nowadays, we are more conservative, 1 and even less width. Flaring is very important because it makes me see the apical region or address the apical region easier. That's why we can choose 0.04 or 0.06. We don't want to go more to the 0.08 because this will weaken the tooth. So the access of the apical region is very important because I want to clean it very well and obturate it. And this is some sample of the rotary instruments. The ProTaper Next, you can see that the orifice width is 1.2. I really emphasize on decreasing this. Irrigation is very, very important. We always use sodium hypochlorite, or we may use chlorhexidine because they are both very, very good antibacterial agents. And alternately, we use EDTA because EDTA removes the smear layer and opens up the dentinal tubules and lateral canals. This is very, very important. After that, we flush the area with normal saline and the canal is ready for obturation. The needle, of course, has to be side vented and has to be within 2 millimeters from the apical constriction for maximum efficiency. Of course, we have to do some kind of vibration or agitation to the irrigant material, whether it is sonic or ultrasonic, because it is important that the bubbles and the irrigant moves about in the canal and removes as much debris as possible. Root canal lubrication is nice, for example, Glide, because it has 15% EDTA. It makes the debris gets clogged in the gel, and by irrigation you get more debris removal. These are cases of my MSc student, Dr. Huda, and she made an SEM study after treating the root canal wall with different ways. You can see that the different concentrations of EDTA. This is no treatment with EDTA. This is a low concentration, and this is a very, very high concentration. You can see this, the smear layer here is completely gone. Lateral canals, if they are present, they will be opened nicely, and here it is ready for obturation. Root canal medication here, I really don't like calcium hydroxide because removal of calcium hydroxide was documented that it cannot be removed completely. That's why it will clog the lateral canals or dentinal tubules, even with ultrasonic agitation. I always like photoactivated disinfection. Obturation is very important because you are going to close all the spaces and adapt to the root canal wall nicely, but it has to be adapted nicely in the coronal, middle, and apical region, and even in areas that are isthmi, accessory canals, and lateral canals. The core carrier gutta-percha technique is very nice in such cases. For example, the thermophile cone, I always use it. It's a plastic core coated by gutta-percha. We heat the cone and we insert it in a vertical pressure until it reaches the apical region. The cone, the plastic core will act as a spreader and a plugger at the same time. So it will enter vertically and laterally to exert good pressure, so any lateral canal will be filled. It is very easy and fast, and as you can see here, many lateral canals were filled by this technique. After placement of the cone, you can remove it with any burr, remove the excess with any burr. So it is important that the sealer and the gutta-percha seal the apical region very nicely to prevent microleakage. Cases. This was a case with a tooth that has a big lesion, and the lesion is spread both apically and laterally. After obturation, you can see the lateral canal and you can see the lesion has receded. This is a molar with two lesions, one in the mesial, one in the distal root. And as you can see here, there are two lateral canals that are present at the same level in both roots. Follow-up is very, very important because these lesions associated with lateral canals, they have to be followed up to see the progress. So this is a big lesion associated with many lateral canals. The tooth was obturated, and the sealer puff ensures that our obturation is complete. And you can see that after 9 months, total healing is done. This is another tooth with a lateral spread of the periapical lesion, and a tooth that needs retreatment. And you can see the lateral canal being filled. And this is a multiple lateral canals in one tooth, 3 lateral canals, and associated with the periapical lesion. If we don't treat all these lateral canals and fill them, healing is not really going to happen. Literature always states that bioceramic sealer or any type of sealer may make a good hermetic seal in the apical region, and this is what is very important. It's important to seal the area apically. And thermoplasticized gutta percha, and namely the core carriers, will make a good seal of the lateral canals, as you can see here. And this is the core, and this is the gutta percha entering in the lateral canal, and before that, the sealer. So it is imperative that our goal should be here. So in the end, we have to keep the apical constriction as much as possible in order to prevent unnecessary extrusion of sealer, but at the same time, our goal has to be here. The lateral canal has to be cleaned and filled because the lesion is here, not here. So the take-home message is keep the apical constriction as small as possible, let the body defense does its role and give it time, and most of the periapical lesions heal without invasive surgery. Anyone interested in more lectures, I've got my YouTube channel, Hussain Al-Huwaisi. You can see them. And I've got many cases that were published by Endodontic Practice UK. You can revise them too. Thank you very much.